Welcome back to Mastering Change. Today we're exploring the therapeutic use of psychedelics in healing trauma. This is a topic that is somewhat controversial. However, it's increasingly relevant in the world of trauma healing. My guest is Dr. Chantell Thomas, a clinical psychologist and the executive clinical director at Windrose Recovery. She spent years working with ketamine, MDMA, and psilocybin, and has seen how these substances, when used ethically and intentionally, can help people reconnect with parts of themselves that trauma has pushed out of reach. In our conversation, we talk about how psychedelics can interrupt unhelpful patterns, why the therapist-client relationship is so central to the process, and how true healing isn't about fixing what's broken, but about remembering your wholeness. It's a grounded, honest look at a field that's full of potential, yet often misunderstood. Let's dive in. It gives me great pleasure to welcome Dr. Chantell Thomas to the podcast today. Welcome.
Thank you. Thanks so much for having me.
So, as most of our listeners will now know already, we start every podcast with a little ice-breaking card game. It's called Where Should We Begin? And on each of these cards that I've got here, there's a prompt. And the idea is that you just answer the prompt in whichever way feels most easy and natural to you. So I will pick a card and it says, my greatest power struggle is with ...
Ooh. Internal or external?
Both and neither.
I don't know if it's a power struggle. Maybe it is. It almost always comes down to parenting and my fantasies of like just responding in the most attuned and available way for my kids. And then the part of me that doesn't, that I watch in the moment. This morning, I had one of those this morning. Actually, I think I did okay today. But a lot of mornings I see myself unraveling in real time. I'm watching it. I'm thinking, okay, when is this going to come up in therapy for them? I know better. I'm watching it happen. I know about attachment. And it's like, so ideal parent versus actual parent. Maybe that's the biggest conflict. That works outside and inside as well, I suppose.
Absolutely. And I think anyone with children will be able to relate to that. I think especially those of us who work in this space, because as you say, we know exactly how we want to show up. We are supposed to show up and how, those things that might cause long-term damage. But, I think for me as a parent, the best thing I've learned from working in this space actually and being a parent is that repair is possible. We will rupture will happen, right? Yeah. Rupture will happen, but as long as we are prepared to make that repair, I think we're good.
I have a great story for you. It's a quick one. So my youngest is 7, and I'm big on rupture and repair. It's probably been my guiding principle as a therapist, and particularly a relational trauma therapist, even more so since I started working on clinical trials involving MDMA-assisted therapy. But my youngest, I was in the middle of what I thought was a fantastic repair session. And she looked at me very sincerely and said, yeah, Mom, I understand, but why do you keep doing it?
Oh, God. She's wise beyond her years. How did you respond to that?
It's like, don't say you're sorry, change.
Absolutely. Oh, God.
Yeah, I just said, yeah, I'm kind of wondering the same thing myself.
Wow. Good for her.
Yeah. I was delighted. I was delighted in the moment that something must have gone well for her to be like, yeah, this is a nice exercise, but I'm just interested in it changing.
Well, that's a great story. But tell me, you sort of mentioned there a little bit of your background, but if you could introduce yourself in your own words.
So I'm a clinical psychologist. Actually, I did a health psychology specialization. I got licensed, feels like quite a while ago now. And I'm based in Madison, Wisconsin. I'm an executive clinical director for a residential treatment facility called The Manor and Windrose Recovery. We also have an outpatient ketamine-assisted psychotherapy program called Integrata. and a professionals program called Positive Sobriety Institute in Chicago. And then when I'm not doing all those wonderful things, I do clinical trial research with psychedelics for therapeutic purposes at the University of Wisconsin-Madison across a number of different compounds. And I also do consulting, clinical consulting for Lycos and teaching for Fluence, which is a psychedelic and harm reduction integration platform and training avenue for folks who are interested in psychedelic therapy. So quite a few things going on.
Definitely. And you're kind of, when did you start to specialize in the kind of psychedelic assisted therapy?
Yeah.
Away from the kind of traditional therapies.
Yeah. Well, I one thing I will add is I don't see it as a moving away from, which is actually really great. That's probably been the most exciting thing about working with psychedelics is it's informed me to be a better therapist, I think, when no psychedelics are in the mix. And it's very congruent with the forms of trauma therapy that we do within our program when we're not using any form of psychedelic medicine. But I would say my first working on a psychedelic trial was 10 years ago. It was a high-dose pharmacokinetic study for psilocybin, just to demonstrate the physical safety of psilocybin in high doses. And that was at the University of Wisconsin-Madison in the School of Pharmacy. I worked as a psychologist doing screening for that trial and also as a facilitator. I'm actually right now on the campus of the USONA Institute, which is a phase 3 sponsor for psilocybin for depressive disorder that's happening right now. And I work to do consulting, clinical consulting on that trial and support of the facilitators across over 30 sites. So it happened a while back, but I would say probably working on the MDMA-assisted therapy trial and learning about that integrative, interdirected therapy, which was heavily relational, process-based, somatically, tracking somatically, and really honing in on this principle that people do have what they need inside if there's optimal conditions aligned. And I think the work I was trained historically through graduate school in exposure-based modalities for trauma treatment. And what really excited me about the right application of the right compound in the right set and setting is that psychedelics can serve as a resourcing tool for people who so desperately want to get better, but they just have such a hard time navigating kind of the harshness of their interior or the places that stay blocked, that even though they consciously want to move them, just can't move out of protection. And then, of course, the work of Janina Fisher alongside of that, these more resource-based models, certain forms of EMDR, definitely looking at creating more safety inside somatic experiencing had a big impact on me after I hired a somatic experiencing therapist to work at our treatment center 8 years ago. So it's really been this coalescing of all these different orientations in some ways that fit kind of hand in glove to using psychedelics as a tool for trauma reprocessing.
Can you explain a bit about how your treatment center then would work with someone who is coming in with some form of trauma?
So we're primary substance abuse residential center. We're a fairly small center. We have 11 beds. So most people come to us saying, I just need help with this substance use issue. I would say maybe 25% of the people coming in know that there's a trauma-related issue that kind of intersects with their substance use. But I would say the vast majority of the patients that we treat are not aware of the ways in which kind of traumatic circumstances or more often emotional neglect, lack of safety in childhood, inability to be attuned to due to their own parents or primary caregivers suffering from their own issues. And so, the program's I tend to operate from a very emotion-focused place. And so what we look at when people first come into treatment is how much access do they have to themselves? Do they have the ability to express or identify the full range of feelings? And then if they don't, that becomes an interesting template for understanding how might they be using dissociative processes that they're not even aware of, and how is that kind of impoverishment of ability to identify, name, access, feel, and express those emotions directly interplaying with their relationship with the substance. And so then the first several weeks in treatment is understanding that, the internal mapping of their system, and then understanding them in the larger family system that they have, and recognizing how is that system adapted, who are their primary people, how do they fit into that equation. So getting a roadmap for what we might need to do in treatment. And so for some people, that we can resource more effectively based on what they're navigating, they might start doing trauma reprocessing around week 3, after they've done a lot of resourcing work. The combination of IFS-informed principles, EMDR, and then for some clients, not the majority, we might also include ketamine-assisted psychotherapy as a trauma processing tool alongside of the other work that they're doing, including the somatic experiencing and the EMDR.
I think it's really fascinating. You can kind of explain, like a while. I'll ask you again about the kind of results of the studies that you've seen for with psychedelic assisted psychotherapy. But when it comes to addiction treatment, I think there's always this kind of hesitation, rightfully probably, to kind of open Pandora's box when it comes to looking at trauma, because people are coming in with this substance issue, which is what is basically kind of threatening their lives, and they need to get under control. And then to often the feeling can be opening or to kind of scratching the surface of past issues or past experiences, and then they might need to leave. Often treatment is only lasting 28 days or only lasts 28 days. So I find it, what I'm really hopeful for, I think, is that using things like psychedelic assisted therapy, which can, and you'll need to explain this better to me, expedite potentially the trauma healing, and doing that first of all within a treatment center setting, that's obviously safe, and you know, as you said, set and setting is so important, but doing it there and then potentially for a period of 3 months having kind of sessions and then going out and maybe having follow-up or integration outside, I think could be really revolutionary for the substance abuse world. But I'd like to hear you.
Yeah, I completely agree. Having worked, all the trials pretty much that we work on, the psychedelic trials, and the only one we've done at University of Wisconsin-Madison or been a site for that has specifically focused on PTSD is the MDMA-assisted therapy trial. There have not been very many trials looking at PTSD. Just now, there's starting to be trials looking at PTSD using something like psilocybin. That work is very nascent. Most of the psilocybin research is focused on depression and addiction, or substance use disorders. So MDMA-assisted therapy really was the first significant phase 3 trial that had the indication for working on PTSD. Ketamine is a really interesting player in the psychedelic space, because when you're working with PTSD, you're working with an off-label indication. There have been some trials looking at trauma with ketamine, but not really robust, no phase 3 trials that have been looking at a specific therapeutic intervention. And this is also the interesting nexus point is, are we looking at the compound itself as doing most of the work? Are we seeing it companion to a therapeutic process? There's some psychedelic clinical trials that lean really heavily on the medicine itself or the compound itself, versus those who really recognize the role of quite skilled and nuanced facilitation, which I say would be the case in the MDMA-assisted therapy trials, particularly because when you start working with relational trauma, as you may know, once you get into those relational networks, especially when there's been a lot of betrayal, and complex trauma, it gets really messy and things get really hard and difficult. And we're getting into the feeling of perpetration networks and working with the shadow elements of that. Um, so so that's one distinction that I think is just important to name, is just to say psychedelic assisted therapy for trauma is just like too broad in some ways. Because when you're talking about different compounds, it's a very, potentially the mechanism looks a little different. What is the therapy that's accompanying it? Um, but I completely agree with you that the opportunity to, in some ways, accelerate or catalyze a therapeutic healing process by using a compound that potentially helps people access something new, different, um, that maybe is very well compartmentalized or cordoned off or dissociated from. There's great opportunity. There's also great risk with that. And the residential environment provides the opportunity. What I've seen, which is very exciting about residential, a lot of people think it's a big investment and why would I do that? And I can do it in outpatient. It's very hard to do intensive trauma work on an outpatient basis because people have to shore themselves up. And I think there's a misnomer that if people want it bad enough, they'll go deep. And that's not been my experience. It's actually it's about aligning optimal conditions where there's sufficient safety that people can get access to things. And it's very hard to do that sometimes on an outpatient basis. It's also hard to do it on an inpatient basis. But if you can align the conditions and you do enough resourcing work and you make sure that someone there's great alignment in the treatment targets, because that's the other piece is you use a psychedelic to blow past defenses that you think are a great idea as a clinician, but the client is like, that's not what I wanted, or that was way too much, or I went way too deep and I wasn't ready for that work. There can be a real feeling of betrayal or feeling like they were exploited or misled or abandoned in that process. So it's very important, I think, with trauma work that there's really strong relational alignment. There's co-agreement in what the goals are. And then there's also this capacity and conversation around informed consent that we don't really know what may come forward. What is the agreements that we have together for how long we're going to work with this to ensure that something doesn't get kind of shaken loose and then you're discharging in 2 or 3 weeks and now you're in a more vulnerable spot than when we started. So yeah, a longer commitment of time in a residential environment with an accelerated therapeutic process that really allows people to go deep as possible. To me, when the conditions align for that, I think it will revolutionize some things in the residential treatment world. I can't imagine it's not going to.
No, I totally agree. I mean, and it's exciting. I mean, it's exciting until, you get over it. I mean, you guys in the States, it's the FDA that kind of didn't approve
Yeah.
this happened end of last year.
Yeah.
Yeah.
Yeah. A lot of complexities to that conversation and that decision and what did that mean, and where, the tricky bit of business when a therapy is coming alongside of a drug that's trying to get approved by an agency that doesn't quite, that's not their area of expertise, is the therapy land, right? And so, yeah, interesting precedent. Interesting to see what will come next in terms of psilocybin, and will they downplay therapeutic elements that are absolutely happening in these clinical trials with psilocybin just to not flag that on the radar of the FDA and call it psychosocial support purely when we know there's therapeutic elements happening.
But that worries me. Doesn't that worry you if they do that? Because I think
It does a little bit, yeah.
I mean, you touched upon the compound is, I think you said, plays a part and a big part in what you're treating. Actually,
Yeah.
the most important piece of any, for me, psychedelic assisted therapy is that relationship with the therapist. For any person with a past history of relational trauma, that relationship with their therapist is going to be the most vital part of their healing journey. The drugs and everything you give, but it's that they need to, where they need to trust in and work on, and so
Yeah. Absolutely. No, I could not agree more about that. Now, I try to always hold in mind that I have a bias in that way because, it's the work that I do. It's what I see. I can't fathom it going differently. A good parallel conversation is, you have a lot of therapists that get trained in trauma treatment modalities such as EMDR or somatic experiencing or IFS. You can be skilled in things that we know work really well for trauma, but it's the therapist and how they apply it and the relationship that really mediates the success of that intervention. And I would say it's very similar when you bring a psychedelic in the mix.
I
The rela
agree.
Yeah.
But I think, and I've actually had conversations with other people
Mhm.
about the. I don't necessarily. It is the person that's in part of that process, but that person doesn't necessarily even have to be. And you might contradict me,
Mm.
Kate, but
Yeah.
necessarily have to be a therapist. They have to be able to be caring, and they have to have a lot of personality traits but that
Mhm.
could be, and a nurse may have those personality traits. Many mums may have that personality traits, but they need to be someone when you're going through a journey or having a psychedelic assisted experience. I,
Mhm.
I think you need to have someone there. Needs to be some sort of relational aspect to that process. Does it need to be an IFS therapist, an
Mm.
EMDR therapist, a
Mhm.
trauma-informed therapist? I don't know. That's a question I guess I'll ask to you.
This is the big debate, right? And again, what I want to do is distill it down because I think the answer is different depending on the condition, the nature of the trauma or the nature of the struggle. Um, which compound are we talking about? There's no question that the way that I feel myself in the room when I'm supporting a psilocybin session is very different than when I'm in with someone who maybe doesn't have a really strong clinical indication, or even with the depressive disorder. I feel more, I'm alongside of the journey, but I don't feel centrally involved in the same way that I might be when when I'm working with a compound that's more relational in nature. And that's not to say that psilocybin work isn't relational work. I think it is as well. Because I think there's a common misconception that psychedelics just go in there and they just like open up or bust through or access something deep for everyone. A lot of these journeys look like struggle, stuckness, struggle, disappointment, frustration with self. There's this inclination to, when people have the choice around dosing, I need more when they encounter blocked places inside of themselves. That actually requires a lot of nuance from an experienced clinician that might know how to detect a process that's underway as opposed to just leaning into more medicine or leaning more heavily into the compound. So depending on the nature of the now there's another person that might do beautifully with a very supportive, warm, compassionate presence who's just holding space. And then the next person that walks into that clinic, despite looking very similar in many ways, might need a very skilled, thoughtful, nuanced capacity to kind of differentiate what's happening in real time and what happens when someone accesses something terrifying that induces some paranoia. And they all of a sudden stop feeling safe in the room. Might you want to really pull on some of those psychotherapeutic skills that you have to navigate that in maybe a different way, depending on your experience? Might someone intuitively know how to do that without any sort of that training? Possibly. I think it's a little less likely. Um, is presence enough? Where do you need skill? I mean, I think this is the conversation that we don't have granularity on yet. And I know there's work happening in Oregon right now in the wellness clinics where you don't have to have more than a bachelor's degree to sit for someone in a psilocybin journey. And fortunately now they're collecting data on it. They weren't initially collecting data, but now they're getting more data on adverse outcomes and that sort of thing.
I mean, for me though, more than a bachelor's degree, which definitely
Yeah.
shows intelligence levels, fine. But actually,
Mhm.
I think there's character traits, personality traits that need to be there rather because
Yes.
yeah, and that's
Yeah.
how do you test or you know
Yeah.
interview for that? I mean, you get, I guess you have, but that's almost as in, in fact, I think it's more important than the bachelor's degree, to be totally honest.
The bachelor's degree is not sufficient, it's one barometer, it's one marker, and I couldn't agree more with you. What we're talking about, I think what you're talking about, what I'm talking about is presence and availability and the capacity to stay really regulated and grounded within your own nervous system, know yourself well enough to know. I mean, the other piece of this is triggering work for everyone. You're encountering death, sometimes suicidality, shadow, dark impulses at times, fear, sorrow, grief of an intensity that a lot of times people struggle to access in our culture and society that only allows for a certain amount of emotional display, intensity, rage, screaming, yell, I mean, all of those things that evokes historical patterning for people. And if they haven't had a lot of experience working with that, if they don't know when they're getting activated in the room and it's not just about holding space for someone else, it's navigating your own stuff. There's so many nuances here, right?
And I mean, I think that what you're talking about, that is the skill of a great therapist, that to know how to hold space when all of those kind of big emotions come up in a
Yeah.
or when something comes up that triggers the therapist, they're able to kind of feel that and say that's not this person, that's something that's coming up for me. So I think that is a therapeutic skill. So then we kind of swung back around saying maybe you do
Yeah.
therapist to be able to
I
do
mean,
this. But
I think there's going to be a need, and Bruce Poulter is one of my mentors. He said this the first time I heard him say it. I thought, yeah, that's so smart. When we get better algorithms for identifying who's going to need more nuanced, skilled, therapeutic presence, well, always therapeutic presence, but being able to pull on those skills, having a lot of self-awareness and recognition of the triggers that might be happening. Even this idea, how do we diversify that? Understand which compound might be most appropriate, what type of facilitator, how many sessions might be needed for people who can only afford one session. Does that leave them in a worse spot if they can't afford 2 sessions or 3 sessions? All of these nuances are incredibly important. And we don't know all of those things yet with granularity. So this is a very interesting time that we will be, that we're treading into and continue to traverse.
yeah, and yeah, as you were saying that, I was just thinking also, I bet, there will be people who can just afford one session, but possibly best outcomes, and this is always the case, isn't it? People who are well resourced financially can probably achieve the better outcomes, maybe, is if you've had a long history with your therapist, or not long, but certainly long enough so you have this therapeutic relationship prior to even going into a session, and then your therapist will know you and know how to work with you. If they can also work with medicine, then even better, I imagine.
I mean, it's so interesting. I mean, this is coming up in the ketamine assisted psychotherapy world because there's this decision that's being made by clinicians when they offer ketamine assisted psychotherapy. Do people want to do CAP with their own clients, or do they want to be like a specialty add-on to existing therapeutic relationships? I see real value in both models. In some instances, these really well-worn, deeply intimate relationships with therapists, it's just a fact of human nature, the way we see people and the patterns by which we engage. They they get they get well grooved. It's hard to bump out of those tracks. And sometimes what's happening in the presence of a psychedelic compound is one of its primary I would say impacts or opportunities is the fact that it's disruptive. It disrupts the patterns and it reveals something different inside. It helps people get out of loops. It bumps them out of the stories that they have, the way. So sometimes if you have a really patterned relationship with a therapist, and everyone does, and I'd love to say all therapists are getting supervision and they're aware of how they pattern with their patients, and we just know that's not true, right? Is the gift of being able to see something new. And sometimes that's really, I've had clients that I worked with in these trials that are like, I can't go back to that therapist because the way they are with me and the way I am with them, now that I've seen this thing new, I don't think I can go back there, or I just don't know how to bring that into our work together because it just feels so different. And so it's such an interesting question. But I think your instincts are spot on. There's so much therapeutic work that people can do leading into these journeys that better potentiates the success of them. And that's the other thing that I think is culturally misunderstood, is that there's too much pressure on the compound or the psychedelic medicine and not enough consideration of the internal environment or the resources that individual has or the self-awareness. The preparation is insufficient. People are not prepared for what happens. They don't understand what destabilization can look like in the presence of a psychedelic compound. We know this in trauma work, but a lot of people who haven't done trauma work don't understand what destabilization looks like. What happens when one person around you goes, oh, you're worse, and another person goes, oh, this is good, right? Like there's all these complexities that are not taken into consideration and set people up for potentially very frightening, alienating, isolating disruption alone without people to help them make sense of it.
And then, so you then exactly, you talk about, so
Yeah.
what is so important, the preparation that's happened, and then
Yeah.
equally,
Integration.
if not more, and that's, for me, that this most scary, biggest
Yeah.
piece, that, but that
Yeah.
people who are not in the trauma world, and maybe even
Yes.
some people in the trauma world, they just think that they can go and take these medicines with or without a therapist and just be, or somewhere, I don't know, go to the middle of the jungle in Latin America or wherever, and then think that, oh my God, they'll have a big experience. Of course they will, and they might
Yes.
notice shifts happening. But then they're not doing anything about it. And I'd love you to speak a bit into that.
Yeah. We named our ketamine-assisted psychotherapy program Integrata, built off of the concept of integration, because I it is essential, it's necessary, it is, when you're working with these non-ordinary states of consciousness that are occasioned by psychedelic medicines, that's not the only thing that occasions it, right? A deep somatic experiencing session can occasion a non-ordinary state of consciousness. I see it happen all the time. So can EMDR, for that matter. So can holotropic breath work. So can a lot of different things, right? We're going into a part of the psyche that is a little less trafficked in our hyper intellectual, hyper labeling cognitive society, right? And so we're working with more felt sense networks, less verbal, more abstract, emotional. It's not linear. If we want things to be impactful and sustainably impactful, we have to re-bridge the conversation to the parts of us that need a story, a narrative, need to make meaning, need to understand what might be inexplicable, right? I've seen a lot of people have a really big experience, and sometimes the person that's trying to integrate them goes, just trust the process, you're not going to be able to make sense of it. That's all well and good. It's not very fair to the individual, though, right? Like, how many people, when our whole society is built on the concept of meaning making and explaining and finding an algorithm and a solution, are going to be able to tolerate that? So we have to find ways to honor what has come through and hold it while it's still evolving without squashing it by labeling it prematurely, but also providing a framework so that someone can actually cultivate the unfolding of it instead of panicking or overriding it by a hyper intellectualization or a definitive conclusion prematurely that doesn't actually map on, because we're so panicked about this uncertain. The great news is something new emerges. The bad news is something new emerges. And we all know uncertainty, unpredictability, particularly in the state of someone who's traumatized, is the same as a threat. So how do we kind of find that sweet spot of honoring what's coming forward, giving people enough resourcing and contextual framework and therapeutic support to let them be on that journey of letting it continue to unfold, versus letting them just drown in the soup of it and saying like, "Oh, it'll all become clear at some point," like that is also very unhelpful. So the I would say the nuance of really good integration work is a skill that I'm constantly challenged by as a clinician, 20 years in the field, feeling like I had some mastery in some areas. I Part of what I love about working with psychedelics is the creativity it requires, the nuance, the watching my own edges to overpredict or label prematurely, all of these things that I maybe got a lot of credit for in certain therapeutic environments for my great insight, right? Those things are my edges I have to constantly watch in psychedelic work. And I have some days where I feel like I'm in my sweet spot and other days where I'm overtired or I have a really big fight with my kid that morning where I just over talk, over explain, over label, and I don't create enough space for their experience.
I think that everything you've said just sounds like you would be an excellent, absolutely excellent person to have, in a psychedelic experience. It really gives me great hope in an area that I think there is fear. There's people, certainly the lay person who has had all of this kind of mis misinformation around psychedelics and to hear that people who are using it in what I would consider the safest way, which is to, as you say, this preparation and integration piece is the most important thing. But I guess again, it comes back down to this idea of what happens if people can't afford
Yeah.
that. Because I mean, how long does integration need? How long does preparation, how many preparation do you need to have and integration do you need to have? The truth is the longer, I think, I don't know, you can tell me again, but surely the longer the better, the more the better in terms of both of those things.
Well, it reminds me a little bit of the specialized therapies that we use for treating trauma right now. I mean, most people can't find insurance that will cover somatic experiencing or EMDR if it happens to resonate, or even IFS for that matter. I mean, this is a problem we know well in our society. The Right now, I'm trying to work on a pilot project with a community healthcare center here in Madison that I used to work with to do CAP with federally qualified healthcare center for folks with very limited resources. Because I think we need to find inroads at the primary care level to be able to kind of create basically do more trial opportunities with individuals that are very low resourced, because this is an interesting question, right? But we have this problem now. I mean, when I try to refer a friend of mine to a therapist and, they say, I'd love to use insurance, I go, that's going to be a little tricky depending on the type of work that you want to do. And that's not to say that there's not incredible, what I would say, warriors doing the work on the front lines, but it's very interesting to see like what type of therapeutic modalities get the most proliferation, and where do those work well for dissociation, or do they work well for people who are somatically disconnected? I think those of us that work clinically with trauma see the limitations there, and there are still great therapies and good therapies that are exposure based. A lot of people drop out of them. We need more options. We need to study these. We just need more options. There's too many people suffering day in, day out, killing themselves. I mean, the suicide rates with veterans. So this is such an important time. And yes, we have to solve the access issue, but yes, we also have to figure out who is this appropriate for. We certainly don't want to be testing it out on populations that have the least amount of resources. Like that is a dangerous equation as well. So,
And has that happened in the past historically?
yes,
Yeah.
yes,
Yeah.
yes, there's a history of that too. Yeah.
But I think like, and even if this were to get approved, and insurance were to, offer it
Hmm.
or it would be covered by insurance, I still worry about this idea that they would say, great, well, because we're covering this because it is such a like an efficacious therapy. So effective and so quick working. So actually, people only need 3 sessions and then they're done. And I worry that then becomes an even bigger problem because they don't take into account the integration or the preparation.
Yeah. Well, yes. And also, don't we see this happening in the residential treatment world right now? People get authorized for 2 weeks of treatment and then they're out because they don't look like they're withdrawing anymore. It's a disaster, So these problems already exist in our healthcare system. We got to figure out how to work with them. And we need better education, because this is not a silver bullet, easy solution. This is not a bypass. And I think a lot of people think it as a bypass. It's an accelerant. People say, like, it's like 8 years of therapy in one day. I like to say it feels like 8 years of therapy in one day. It isn't just like solving for. What happens next is like you're doing 8 years of therapy. That's what it feels like, right? So there's great promise in that. And then I think anyone I've gone through a psychedelic trial with is like, people don't get it. This is hard work. This is not a bypass.
Or a fun trip either, right? Or like
Yeah, I mean, but there's relief for the first time. There's hope for the first time. There's possibility, but buckle up. I mean, this is not easy work at all.
I totally agree. This has been a really absolutely fascinating conversation, and we could have carried on all day, to be totally honest. But we have a wonderful thing that we ask all of our podcast guests before we end the session, before we end the podcast, and that is, we live in a world that is rife with anxiety, fear, depression, as you said, high suicide rates, and both on a macro scale and a micro scale. If you had one lever or that you could pull, or one button that you could press to make the change that you'd like to see in the world, what would that be?
Can I say two things?
Yeah.
Better financial resources for more skilled therapeutic opportunities for people. That's one piece. We know what's working for people. We don't have the resources to proliferate it across enough people. There are really good therapies with or without psychedelics that work, that are not financially viable, even for people with some resources. So that's one piece. And I think we're starting to do it. Emotion awareness, emotional education. I wish we did a better job particularly with boys, in the way that they're acculturated around their emotional landscape, girls as well, folks who identify as non-binary, just across the board, helping people become more connected to their feelings, but also recognizing that emotional access is a superpower. So those are pieces of it. Last thing I want to say really quickly, thank you for your compliment to me. It was really kind. But I mean, I've learned so much from my mentors and from the clients that I've worked with, and the participants have taught me immeasurably. So while I take the compliment in, it's really just what has been passed down to me through the work that I've had the privilege of doing, and the courage, and making a lot of mistakes.
Yeah, I'm sure. Yes, it's always going to be a collective, collaborative effort, I think.
Yeah.
Space, but I'm glad that you were one of the ones that's chosen to take that baton forward, and keep passing it on, so that you can continue that, great teaching and training, because I think, you're doing a fantastic job. So thank you so much for joining us. It's been an absolute pleasure.
Thank you so much. So good to be with you.